Good afternoon. My name is Dr. Tom Grogan. I'm an orthopedic surgeon in Los Angeles, California. I want to spend a few minutes today talking to you about what we've learned in orthopedic surgery about stem cell therapy, and specifically for orthopedic conditions. My journey with stem cell treatment really started about 7 or 8 years ago when Dr. Mark Berman finally convinced me that there was a future in regenerative therapy, and specifically stem cell therapy. He'd just begun learning a technique of picking up stem cells from fat. He would essentially do a liposuction technique, treat the fat cells, break down the fat cells, releasing a soup of cellular material, inclusive of which are these pluripotential cells that we like to call stem cells. So I want to share first with you our experience, and most recently our experience with our patients with stem cells and the history and sort of how we got to where we are today. One of the interesting things about stem cell treatment is there is really not a lot of good scientific data until the last few years. So when I look back to see exactly what was in the literature, how much research had been done, I noticed that as of about April of last year, there had been about 1,600 peer-reviewed articles, but only about 60 of these articles were actually critical scientific articles focusing upon clinical outcomes in patients. And of these, 7 were randomized clinical trials, which is the gold standard in science. There were 13 comparative studies, a number of case series, and some case reports. So, how do you get to the cells? 60 of the studies we looked at how the cells were deployed, whether they were injected, they were implanted surgically, or a combination of the two. And all these different articles were starting to look at what the source of the cells, where do these stem cells come from? 20 of the articles looked at bone marrow stem cells, which is a technique commonly used by orthopedic surgeons now, where the bone marrow is aspirated. 16 additional studies looked at bone marrow concentrate, where not only will we take bone marrow cells, but we'll be able to concentrate them and distribute them directly to inject it into joints. 17 of the studies looked at adipose derived stem cells, which is actually the type of cell that I'm most commonly associated with and have been for the last 6 or 7 years. 5 studies looked at being able to derive stem cells just from your peripheral blood. One was from soft tissue or synovial tissue biopsy, and there was one comparative study that actually looked at peripheral blood versus bone marrow concentrated cells. So the interesting part is the literature truly is expanding. The first use of stem cells, or mesenchymal stem cells, really dates back to the early 2000s, the turn of this particular century. And most of it was being done in Asia and Europe. And most recently, coming out in the last couple of years. So, the sources we looked at, bone marrow, adipose, synovial tissue, fetal derived, these are all what we call mesenchymal stem cells. There's a lot of work being done right now in science looking at progenitor cells, and these are basically other cells and cellular contents that can be used to derive stem cell-like actions on target tissues. So when you look at bone marrow stem cells, the classic was taking some tissue out of the bone marrow. You put a needle into the bone marrow, you suck out some of the cells, and then you culture those cells. We call it expanded. If the cells are not cultured or expanded, but only concentrated, we call that bone marrow concentrate. So when you look at these issues, the main issue is that when you expand stem cells, you truly have to use different drugs to make that happen, and that has a ton of regulatory issues we're trying to deal with. But even dating back to 2008, when you expand cells and inject them into the knee, and classically where there's holes in the cartilage, we call them osteochondral defects. Even back in 2008, the first study noted improved pain and range of motion scores and appeared to be very, very promising. Further studies in 2014, a previous study in 2012 also looked at osteoarthritis in the knee with injected cells, as well as techniques such as microfracture techniques and bone marrow aspirate techniques. These techniques have actually been very, very helpful in order to determine the proper way we deploy cells and use cells in the future. What else have we learned? Classically, randomized clinical trials have been purported, and those clinical trials, most specifically, that showed back in 2015, where they compared bone marrow stem cells versus just injections with materials we use to help the nourish cartilage, such as Synvisc or Hyligan. At the 12-month follow-up, the follow-up was significantly better with stem cells versus the Hyligan alone. Other studies have shown that, and most significantly after meniscectomy, Dr. Wegness, approximately 3 years ago, looked at using 18 patients that would use bone marrow concentrate as well as hyaluronidase, which is again the Hyligan, looked at bone marrow concentrate showed significant improvement over just the control group. So what this is telling us is that it seems to work, and it seems to work reasonably well in inducing new cell formation. There are many deployment options if you want to put in stem cells. A lot of times, and I'm most comfortable with, is simply injecting cells into the joint. One of the questions has always been, how does a stem cell find the place to go? How does it know to convert itself into cartilage? And how does it know to convert itself in cartilage where we see a defect? We think a lot of this has to do with inflammation. And really, these cells are there being triggered by a specific inflammation of arthritis to cause new stem cells and new material such as cartilage to occur and to deploy. One of the other options is to take those same stem cells and put them in a holder, if you will, a glue or a collagen material that we can put directly into these little holes in the bone and joint surfaces to keep the cartilage material there. There's been a number of techniques, and what we have learned is that stem cells are very effective, even if just injected in the joint or used on one of these deployment techniques, where if we put a device or material in to hold the cells, they tend to stay in those cells and become significantly effective. Bone marrow concentrate's been studied intensively, and it's probably, based upon my discussion with my colleagues in orthopedic surgery, probably the most common way orthopedic surgeons tend to utilize stem cell therapy. And it's easy because we can just aspirate bone marrow right here in our office. We do not need to use plastic surgery techniques or liposuction techniques. It's simple, straightforward, essentially using a centrifuge for the cells. The issue that we get into is how effective are these cells? And although it's been a couple significant studies, as demonstrated here back in 2010, indicated that bone marrow concentrate, either with or without arthroscopic techniques and debridement techniques, are very effective in improving cartilage health, range of motion, and function. In surgical delivery, bone marrow concentrate you can inject into an area directly similar to using the adipose-derived stem cells in areas that you want to have the cartilage occur. A lot of times these are holes in the cartilage we call osteochondral lesions. This good study back in 2015 demonstrated in 56 patients that these cartilage lesions in the ankle had significant improvement at 24 months. By 36 months, although they were better, they did not improve as quickly as they did in the first 24 months. And what we've learned is that patients who were obese or heavier and who had more severe osteoarthritis actually did worse than patients who were thinner or with very early osteoarthritic changes. Peripheral blood stem cells is an attractive option, meaning if you can simply take someone's blood, spin down or concentrate the cells, it's a very simple technique for obtaining stem cells. And there have been a couple studies, one in 2011, 2013, that both showed improvement in this area. What I've been impressed with, though, is that it appears to be the adipose-derived cells give us the most potent cells and give us the greatest opportunity for repair. Further studies done in 2012, 2013 also looked at these osteochondral defects with peripheral blood stem cells. And one study actually compared bone marrow concentrate with peripheral derived blood cells and showed that the peripheral blood cells seem to be better. Now, adipose-derived stem cells are a little bit different. It actually requires you to have a little mini liposuction done under local anesthetic, which is essentially painless. It yields about 50 to 75 cc's, about a third of a cup of fat tissue. The fat is laden with blood vessels, and we've learned that the blood vessels are really where the stem cells are. These cells line the periphery of blood vessels. That's why now we've learned that heating, dilating blood vessels releases stem cells to facilitate healing. One study back in 2014 took these adipose-derived stem cells and actually expanded them, increased them in terms of culturing them and expanding them to larger groupings of cells. And we've noticed that, interestingly enough, a high dose was more effective. So it looks like getting enough cells in place certainly increases the efficiency and the efficacy of what we do. And we've also learned that the MRIs that were done ahead of time indicated that the larger the defect in the bone, the harder it was to get good healing. And that's intuitively obvious. If you have a big area of open area devoid of cartilage, it's going to be harder to fill in that area the larger it is. So when we look at adipose-derived, the real data for adipose-derived tissue, we looked at the injected data. And one of the best studies showed in 2014, 35 patients that had osteoarthritis in the knee, and they had greater than 2-year follow-up. And they noted that basically 76% of the patients they looked at second look arthroscopy had repair tissue. Although it was not normal cartilage, it certainly evidenced clinical improvement and clinical repair. And again, better if the size of our cartilage defect is smaller and if our BMI, which is a measure of obesity, is less. Those patients did better. And we also learned in a study done in 2012 on 50 knees, they did arthroscopy as well as PRP injections, that the adipose-derived stem cell patients were better in the younger age group, under age 55, seemed to be helpful as well. So we're starting to learn a lot of the parameters of what will make a successful outcome. One of the largest studies in osteoarthritis and multiple joints was done in 2015 on over 1,000 patients. And they noted specifically clinical improvement between 3 and 12 months, which is exactly what we have observed as well. At a year, 63% of the patients had over a 75% improvement in symptoms. And again, slower healing for patients who were obese or overweight, which makes sense because the way the knee is structured, every pound of weight you gain or lose is worth 4.1 pounds of joint reactive force to the knee. So to put it simply, as I talk with my patients, you lose 10 pounds, it's like taking 40 pounds off your knee. The hip is similar, although it's about 3 pounds of joint reactive force for every pound you gain or lose. So obesity is an issue, weight is an issue, but it's hard to keep the weight down when you hurt. And so one of the benefits we're starting to see is that if we can start to heal cartilage, if we can improve patients' function, we can improve their exercise tolerance, it makes it so much more easy to lose that weight. And that weight just only makes the joints better. Another option for getting cells is to take it from synovial tissue. This is essentially a biopsy technique where you expand the cells. These cells may have the best potential for converting into cartilage-producing cells. We term chondrogenesis. The nice thing about the technique is it's simple. It's a simple little aspirate with a needle. Currently, because you have to culture the cells, we have, again, the regulatory issues that ultimately that will survive and resolve. But for right now, it has great promise for the future. So where are we on our data? A paper published by the Cell Surgical Network by Drs. Berman and Lander in this year, 2017, looked at almost 1,700 deployments. That's of cases with stromal vascular fracture, fat-derived stem cells. And they found an amazingly small number of problems. There were 13 local infections, little inflammation at the site where the cells were taken from. 8 from the liposuction site, 5 from the deployment site. 2 small hematomas, a little bleeding at the deployment site, 107, which was termed mild. No patient had a significant long-term complication. In our long-term follow-up of 515 patients, we found adverse effects really in less than 2%. So this is a safe procedure above all. How we do clinically? Well, looking at pain and function scores, 83% of our knee patients rate the injection success. And that's primarily a decrease in pain and increase in function. 80% of hip patients, 81% of shoulder patients, cervical, thoracic spine patients, all demonstrating significantly success with these stem cell injections overall. This is just graphically same depiction of the data, which indicates that knee pain continues to improve even over time. Even the 2-year data, which is the data to the far right, you see the bar graphs increasing. Hip pain similarly, we still have effective at 2 years. I hear all the time, how many injections will I need? How long will it last? And the answer is, we don't really know. We have about 5% of our patients that do really well and end up with a follow-up injection somewhere around the 5-year mark. We're starting to pick up more of this data, and the key will be to be able to understand exactly who would we expect to need a secondary injection. All of this is evolving over time. Our shoulder data, very similar. The key is when you look at a graph like this, you see the bars increasing even at 2 years to the right. You see tremendous decrease in the pain and function overall. So where are we in 2017? We're still very early in the scientific process. There are very few really truly randomized controlled studies. Most studies have very few patients. There's still some open questions. Platelet-rich plasma. We know it has growth factors. Do we add it to the mesenchymal stem cells? Really, when I talk to patients, when we do the stromal vascular fraction, when we aspirate the fat and we hydrolyze the fat with an enzyme to break up the tissues called collagenase, what we're really left with after we centrifuge it down is a number of these pluripotential cells we love to call stem cells or mesenchymal stem cells. But actually, it's more of a soup. And that soup really has all kinds of growth factors, not of which we really know, but things that clearly are helpful. So the key question is, what's in that soup? And that's really where we're going to be focusing our attention over time. I mean, it's sort of analogous to the days when you would have a cold and your mom would bring you chicken soup. You're not sure exactly, in the beginning it made you feel better, so you love the chicken soup. Then you start to wondering, what is it about chicken soup that makes a viral illness better? That's where the science comes in. That's what we have to study. We really need to study this chicken soup. In conclusion, stromal vascular fraction, aspiration of mesenchymal stem cells, or bone marrow aspirate for that matter, truly is safe. No real true adverse effects. This is your own tissue you're getting back again. We know that there's a clinical benefit in most of the studies, regardless really of where the cells come from or how they're given. We know that the MRI studies and second look arthroscopies show that this is very real positive change. And we really need to manage expectations of our patients. There are certain patients that seem to do well. The younger age patient, the lower BMI, which means the lighter patient, the less obese. The earlier stages of arthritis seem to do better. Surgical scaffolds, in other words, a way to hold the stem cells, may be appropriate. And they certainly cost less than some of our old cartilage techniques of culturing. And really, exactly how many stem cells do you really need to inject to have an effect? We still don't know. We just don't know how much chicken soup is effective yet, but we'll find the answers. So what's the future? We need more collaborative efforts by investigators all across the country to develop meaningful, randomized, hopefully, clinical trials. We need to continue to share and to develop data. We need to be willing to change techniques as the data sort of pushes towards. And above all, we have to overcome this regulatory resistance to cell expansion that really can only benefit our patients. We all want it to be safe. We know it's effective. There's a number of questions that have been sent in that I hope I can answer and give you some more insight. But one of the things I wanted to focus on first is why adipose-derived stem cells? Why do I do adipose-derived stem cells versus bone marrow concentrate, which would be technically easier? And the answer is the cells seem to be more effective. All the data that I have seen suggests that the adipose-derived cells are probably 2 to 3 times as effective as the bone marrow cells, mainly because the bone marrow cells are almost predestined to be in the bloodline, white blood cells or red blood cells. So I believe firmly that adipose-derived cells are the future. Secondly, I do believe that in the future, adipose-derived cells, we need to be able to store them in the with techniques such as putting them in frozen concentrate so that we can use them in the future. That we can thaw these cells and ultimately expand them, culture them, get more and more of these cells to become more and more effective in the future. Third, what have I learned when it comes to patient selection? Who does well? And more specifically, who doesn't do well? Well, if you think about the stem cells are really anti-inflammatory. They're the ultimately anti-inflammatory. They're helping the inflamed areas heal. And part of that healing comes from producing new tissue in that area to aid in that healing process. So clearly, the stem cells do well in early arthritis. Clearly, they do well where inflammation is the primary source of pain. In the spine, I don't think we know yet. If you have a herniated disc that's inflamed, I think it can help tremendously. If you have bad spinal stenosis, and there's really mechanically a pressure phenomenon that's really causing the problem, I'm not sure it's as helpful. One of the questions I was asked was, a patient had meniscus surgery 2 years ago for arthritis, didn't have any improvement, and that's not uncommon. What we've learned is that if you have a degenerative meniscus tear, remember the meniscus, the cartilage inside the knee, which in the meniscus is one of the cartilages in the knee, and there's the joint cartilage. That cartilage is nourished by joint fluid. That fluid diffuses in and out of the cartilage matrix. When we do arthroscopy, we in essence wash out all of the cartilage synovial fluid. And that synovial fluid, in essence, is what's nourishing the cartilage. So we in essence starve the joint when we do arthroscopy. So it's not uncommon if you have a degenerative meniscus tear or early arthritis, which we used to in the past frequently do arthroscopy. It's not uncommon at all for the patient to get actually worse over time. It would be so much more appropriate, instead of doing an arthroscopy, to simply put in stem cells and will allow the healing to occur as opposed to continuing to damage the joint or starve the joint. Another question is mesenchymal stem cell different than bone marrow concentrated stem cell, adipose-derived stem cell, peripheral blood stem cell, or synovial tissue stem cell? No. Mesenchymal stem cell just simply refers to the fact that our body has stem cells in its system and has had for millions and millions of years. Since we're born, we have stem cells. All healing occurs essentially with stem cells. They will spot an area of inflammation, go and change. If you have a fracture, those stem cells will form new bone-producing cells, or osteoblasts. If you have arthritis, they'll form cartilage. If you have a heart attack, they'll go form cardiac muscle. What triggers these mesenchymal stem cells to make the various target tissues is complex and really not completely understood, but it has to do with all these little humoral factors that are inflammatory factors that are around damaged tissue. It's one of the reasons we've found that simply treating inflammation with anti-inflammatories doesn't really solve the arthritis. And if anything, it may decrease our body's ability to regenerate and heal. So it's funny, we're turning more into a holistic approach now. We really want the body to heal itself. And that's primarily through applications like stem cell therapy. One question I have in terms of spine, and there seem to be a number of questions of spine, is I have spinal stenosis, degeneration of discs, spondylolisthesis, the various spinal conditions. Which one may benefit from stem cell injections? Well, again, the key is inflammation. So if you have a herniated disc, the primary problem is inflammation around the disc herniation. So stem cells may be very effective. If you have a degenerative arthritic condition, we call it facet disease. Again, if it's an arthritic component, stem cells may be very helpful. If you have a pure structural component, if you have collapse of the spine or spinal stenosis that's more bony in origin, it's not inflammatory, then it's going to be marginally helpful at best. In closing, the future for stem cells is incredibly bright. We don't know all the potential. We do know that these cells are constantly seeking areas of inflammation. That's why the research being done, even in cancer treatment, using the stem cells as a source of delivery of chemotherapy, is so promising. And this will continue to evolve in the future. We don't have all the answers. We're barely scratching the surface. What we have learned is it works, it's going to get better, and ultimately, it is the future. Thank you for listening this afternoon.